I am Dr. Lamascus, and this is my class every week. And anytime that Professor McBride is unavailable, which she usually is every week, she really takes ownership of her students, and she will treat you royally, believe me. So welcome to you, all of you. Okay, let's see. Okay, just checking on everybody, make sure everybody's here. Miss Marzal here. And Diana's not there. Nope, that's Lauren. Okay, welcome. Well, what are we talking about this week? We went through some boring stuff last week, didn't we? What are we doing this week? A lot, right? A lot of stuff. And there are a lot of students here, and I apologize if you do not feel like you're just part of a crowd. Speak up today, okay? Speak up so that you get all your questions answered and that you feel like you're part of the discussion. It's going to be a big group, and we do have some time today. I am going to take some time to put you in breakout rooms because you're going to answer some questions for us. You're going to work as a team. You might not know the answer, but get your text. If you don't have your text, well, it's an online text, so you can pull that up separately from your Zoom if you're on your Zoom on your computer. Okay, so pull up Canvas and open up your textbook to be ready when we get to that. Okay. Miss Duarte, you know what? I cannot find you. Where are you? I cannot find you on my roster anywhere.
I mean, I got the email. I got several emails from her, 3 different ways. I mean, I don't know why I wouldn't.
What is it? Do you go by another name?
No, it's very simple. Just Stephanie Duarte.
Are you able to access your assignments and everything?
Yes, through my professors McBride. I've submitted my first discussion this morning. Okay. And I was in the class last week as well.
You were in my class last week. You're supposed to be going to Professor McBride's class. So next week you need to go to her class. Okay.
Yes. Oh, I mean, I think I was with
she's
her,
your
no?
regular instructor.
But she wanted us to attend today.
Yeah, today. Yes.
Okay.
But okay, all right. I'll send her a message.
Okay, thank you.
Professor, I have a quick question. So we're just doing this Zoom meeting with you for today, and then the following week we're going to be with McBride, just to confirm?
Yes.
Okay.
Yeah. She has something else that she is committed to today, so you're just joining our class today.
Awesome. Okay, thank you.
So next week, those of you from Professor McBride will go back to her Zoom, and she will be there. Okay. Does that make sense to everybody? Okay.
Yes, thank you.
You're welcome. There she is. Okay. So I think everybody is. Kristen here today?
I'm here. I'm so sorry about my glitch. I have no clue why it's shaking.
Oh, that's okay. Oh dear. Are we shaking to you?
No, y'all are fine. It's just me.
Okay. All right. Well, welcome everybody. Let's get started again. So what are we talking about this week?
Pregnancy nutrition.
Nutrition is one thing we're going to be talking about. So chapters 6 through 10. So overall, we're talking about changes in pregnancy. What's going on with pregnancy when a woman becomes pregnant? What's going on with her baby? Okay, so we're talking about both clients today, and you have a responsibility for both, right? So we're going to talk about the changes, what's going on, and how do we care for a client that presents to the clinic pregnant. Okay, so before I forget, next Tuesday morning, and I believe I have it set for 9 or 10, I can't remember now. Let me double check before I'm wrong. On my Zoom, next Tuesday at 9 in the morning, I will be on Zoom. You are all welcome. I'm doing a case study that contains all the concepts that we've talked about through this week. Okay, and it's a good preparation for your exam in week 4. Okay, so you're all welcome. I do record it and I will send it to all the instructors. So Professor McBride will have the recording so you can watch it if you can't attend. It's an interactive case study. We're going to talk about a particular client, her history, how to admit her to the clinic, prenatal clinic, and what we do that first clinic visit, which we will talk about today, but it's a nice review to do a case study. Okay, so welcome, welcome. Any questions about anything?
I had a question.
If you're not talking, please mute yourself. Okay, that way. Go ahead, Caitlin.
Yeah, I just had a question about the discussion. I remember
Mhm.
like seeing you pull up a rubric, but I couldn't find where that rubric was. Doesn't it have to be like 3 separate paragraphs in the discussion? Like the first paragraph has to go over something specific.
Okay, I'm sorry.
Can you mute his
Um,
mic? I don't think he's seeing.
So if you follow the instructions, it says it has certain questions. Just answer the questions.
Oh,
Okay.
okay. I
Yeah,
must
just
have
answer
like
the
something-
questions. And I use the rubric to grade. And so you need to,
So as long as we just hit those questions, it
hit
doesn't
those
really
questions
matter if
and
it's
show,
a certain-
and show me that you understand it. So you're going to
Okay.
find an article or you're going to find information in your text, read it, answer the questions, and give me the evidence why you answered the way you did. You can share opinions, absolutely, but I also want evidence, okay?
Okay.
Evidence.
All right.
And as long as you answer the questions and you show me you understand it, you answer in a timely fashion, and you try doing the APA reference style, and I will give you some guidance for your first discussion, okay? I'm pretty lenient with discussion boards. Okay, as long as you do all those things, respond to 2 classmates, and you do it on time, you'll get full points, okay?
All right, thank you.
You're welcome. All right, good. So today, I want to remind you that do not work ahead, okay? So you should be working on week 2 assignments now. I don't want you working on NCLEX yet, because I want you focusing on the content for this week. I would rather you read your book. You don't have to read the genetics chapter, okay? I want you focusing on content and knowledge. I don't want you to spend time with NCLEX yet. You have next week, you can do that, okay? So do not do that. I'm going to put up a video of how to do your NCLEX questions step by step. Your OB calculations, you all should have, in my class, should have more than 1 attempt. In my class, I've given 5 just because it's confusing. And I know Professor McBride has given you at least 2 attempts so that you can resubmit corrections. And then one thing I didn't mention last week, and it wasn't in the orientation, you have 5 quizzes, plus you have 3 quizzes at the very end of the quarter in week 10 and 11. They're just extra quizzes added. Instead of doing Kaplan, we chose to do an extra quiz, okay? Let's see. So this week you do have your first quiz and you have your discussion board. If you need help with anything, you could contact me. I'm supposed to be on PTO this week. As a teacher, if you ever decide to become a teacher, there is no such thing. Okay. And I don't mind teaching class, that's for sure. But I still been doing stuff. But anyway, so organizing myself. So we're going to do some slides, and then we're going to have a breakout session, especially since there's so many of you here. We will have a great discussion. And so have your textbook opened up and we will get started. Okay. Yeah, as far as your videos, please leave them on me. If you're having trouble, just send me a chat. But you must keep them on so I know you're here. If I call on you and you don't answer, well, obviously you're not here. If you don't know a question, just say you don't know. Or if you don't know the answer, it's okay not to know. Okay, that's why we're here. So you will know. So I don't want to embarrass you. I just want to stimulate conversation. Okay. So let's get started. Let's just talk about just this slide about last week. Let's do some review. We talked about women's health care, prevention and promotion. Of course, prevention is always best. And that includes communication and education. And your discussion board question today, it's about unintended pregnancies. And are there things that we can do as a community, in your community, to help reach women, young women, about reproductive care, what's available to them, how to take care of themselves? How do we inform them at an early age that sexual activity has to be driven by healthy lifestyles? Okay, what's available? When should they go to the doctor? We do routine screening beginning age 13. If we have a young woman who's sexually active and we want to educate her, she needs to be educated. She needs to know what's healthy and what's not. What are some signs and symptoms? We need to educate her. What are some very common sexually transmitted infections? Chlamydia. Chlamydia is one of those infections that is very common, extremely common, and probably one of the most dangerous because it spreads through the tissue very quickly and can cause infertility. So it's really important that we teach women about these things. We don't do a pap smear before age 21. And even at the age of 21, if there has been no sexual activity, we don't need a pap smear. Excuse me. We begin testing for HPV in a pap smear at age 26. It's just a request. It's not anything different we do with the procedure. It's just we request it. We do yearly clinical breast exams. Even if at age of 21, or if she comes in at the age of 18 for treatment or education, she thinks she needs a pap smear, we can do a clinical breast exam at that point if necessary, if there's a strong family history of breast cancer. Once she reaches 21, we definitely need to do it every year. And then we can also teach self-breast exams. We also teach, not in female, but in a regular provider office, young men testicular exams, because you know that it's the young men that get testicular cancer. So self-breast exams, we recommend women that are in the reproductive years having periods examine their breast about a week after their period is over. Okay. Because at that point, hormone levels are normal. They're not elevated. The breasts are not swollen. So this is the best time. And a woman becomes familiar with her breast. So if something develops, then she knows it's not normal for her and she can seek help. We also need to do preconception counseling. This is an ideal client, right? This is an ideal state. If we have 50% unintended pregnancies, it's going to be hard for us to do preconception counseling to those who get pregnant, who don't plan it. But getting the word out there, planning a pregnancy is most ideal because we want the woman to be at her best, her healthy best. We want her to be on extra folic acid. We want her to be taking prenatal vitamins before she gets pregnant. We want her glucose to be as close to normal as possible. Any other chronic illness, we want it controlled, okay, before she gets pregnant. We want the woman to have a good weight when she gets pregnant, not to be in an obese range of 34 or something when she's at risk if she gets pregnant. So there's a lot of good we do for preconception counseling. And we talk about this topic in week 5 when we talk about high risk. Okay, so women's healthcare prevention and promotion, vaccines. When should women get vaccines? Rubella, COVID, Tdap, all of those things. Okay, genetics. I absolutely love genetics. If I were to do it all over again, this is probably the field I would go into. Genetics is fascinating to me because there's so much information. So what is this a picture of?
The chromosome.
DNA.
Yeah, that little double-stranded spiral, the helix,
The helix.
is the DNA. Absolutely. That has the genes inside, right? Genes made up of proteins, amino acids, and histones. So we're going back to microbiology. So we have DNA inside the chromosome. Okay. The chromosomes have genes within them. Okay. So, and then chromosomes themselves have certain structures. There's several sets of chromosomes in our body. So let's talk about this. So inside every cell of your body is a set of chromosomes and genes and DNA. And it guides or it instructs all body functions. Okay. So as a woman, she carries certain DNA. She carries certain genes. She has so many chromosomes. And when she conceives, she shares half with a sperm cell who has that same kind of information. So the egg cell and the sperm cells unite and form a, what do you call the formation? What do you call that formation when they're fertilized and it's a conception? What do
An
we call
embryo.
it?
Gametes.
Not yet. It's not an embryo
Oh, a
yet.
zygote.
Zygote.
A zygote. A zygote. Exactly. So the egg is a gamete. The sperm is a gamete. That's a fancy term for what do I want to say? Cell. Okay. So two gametes unite and it becomes a zygote. Okay. So the zygote, if the male is carrying 22 chromosomes and a sex chromosome of an X, and then the woman has the X chromosome, she will always have an X chromosome. It becomes a female baby. So 2 X's. So 46 total. Okay. And then if the sperm is carrying the Y instead of the X chromosome, then the baby's going to be an XY male. Okay. Simple as that. So this is, again, just our information about where are the chromosomes. Big picture. That's the way I am. I need to see a picture. Please just show me a picture. So DNA inside the chromosome, inside the nucleus, which is inside the cell. So all the cells of your body is carrying information. Let's talk about the chromosomes themselves. So normally, an adult and a baby have 22 pairs of autosomes. Okay, so chromosome just incorporates autosomes and sex chromosomes. Okay. So in total, there are 46 normally, okay? And then there are 44 autosomes and 2 sex chromosomes. So in this picture, and we call this a karyotype. If I were to draw some blood from Jennifer and do a karyotyping, this is what she wouldn't have this. This would be a Justin's, because this is a male. Okay, so if you look at these, you can see the 22 pairs. And then down at the bottom where that green arrow is, those are the 2 sex chromosomes, an X and a Y, which means it's a boy. Okay, so sometimes early in pregnancy, if people have money or if they need to know, most insurance companies will not pay for it. We can draw blood and tell the woman if she's carrying a boy or girl. Okay. So XY means it's a boy. So this is a normal karyotype for a boy. So these are the chromosomes that are in every cell. And this one is a female chromosomes. And you can see down at the bottom there where that yellow arrow is, 2 X's. This is to just kind of put a picture in your mind. Sometimes it makes more sense to see pictures. You don't have to memorize this. Now, there's some abnormal chromosome numbers. Okay, remember we have 22 and then 2 sex chromosomes. Sometimes there's more than a pair. If you notice in this picture, the chromosome pairs are numbered 1, 2, 3, all the way through 22. So let's say chromosome number 13. There's an extra chromosome. So there's 3 of them instead of just a pair. And we call any karyotype with 3 chromosomes a trisomy. Okay, so chromosome number 13, trisomy, is called Edwards syndrome. Trisomy 18 is called Patau syndrome. Both of these are neurologically delayed, sometimes don't even survive the pregnancy. Okay, they don't survive much, although nowadays we're able to keep them alive longer, but rarely do they last a year. Severe developmental disability. And then you're all familiar with Down syndrome, right? So that's a trisomy, because that's on chromosome number 21. And I'll show you a picture of that. This is Down syndrome. So we have, you can see here, there's 3, instead of a pair, there's 3. So this is a boy with Down syndrome. We see the X and the Y, so we know this is a boy with Down syndrome. So because a woman's eggs are formed during her fetal life, okay, the eggs are formed during fetal life. By the time that female is born, a lot of her eggs are already destroyed, and she has only a certain amount left. And as the woman ages, so do her eggs. Okay, so if she's greater than 35 years old, she has a 1 in 350 chance for a Down syndrome baby. In other words, if she were to deliver 350 babies, one of them would have Down syndrome. So as you can see, the older is even riskier. So at 49, it's a 1 in 10 risk. Of course, there's other factors that can cause Down syndrome. So it's not only age. Okay. So this is, you don't have to memorize this. This is just showing you the production, why a male chromosome might be abnormal. Okay, so we're talking about abnormal sex chromosomes here. Okay, we've been talking about the autosomes, the 22. Now we're talking about the X or the Y. So when the female's eggs are being produced, sometimes they carry an extra chromosome, like an extra X, or maybe just one X. She has only one chromosome. Or the male is missing one, or the male has 2 X's and a Y. So these are just the different variations of the sex chromosomes. So the 2 that you kind of need to know about are called, one of them is called Turner syndrome. Okay. Turner syndrome is only female. So Turner syndrome is missing a chromosome 23, and it's right here. I don't know if you can see this because the whole picture is what I got, but you can see down at the bottom where the 2 red arrows are that she is missing an X chromosome. There's only one X here and there's no Y. So it's called a monosomy. Monosomy, because it's only one. So what you need to know about Turner, you need to know it's a sex chromosome abnormality. Okay. And women with Turner tend to be shorter, undeveloped female reproductive system. So undeveloped ovaries. She has a webbed neck. Sometimes sterile. She can't have babies. Tend to have broader chest, and sometimes not obviously any kind of mental handicap or neurological disability. So this is Turner syndrome. So these women, sometimes we supplement them with estrogen just to support the ovary. So just remember, Turner syndrome is a sex chromosome abnormality in females and sometimes infertility in webbed neck. In male Klinefelter syndrome is the other sex chromosome abnormality that you need to know about for males only. This one is a trisomy also because it has an extra X instead of XY. Remember back here, let me go back up here. Instead of having just this XY, this male with Klinefelter has XXY. So he has an extra chromosome. There are, and just a side note, there's some mosaicism that occurs in genetics. In other words, there could be a male that not all of his sex chromosomes are abnormal. There might be some cells in his body that have normal. So there might be some characteristics of Klinefelter. Anyway, so Klinefelter is the male sex abnormality. And so you're going to see sterility, okay, sterile, a small penis. And for some reason, they covered it in this picture. It's hard to get anatomical pictures online anymore. They're more willing to show female than male. Sterility, some gynecomastia, in other words, some breast development. And then also sometimes a little speech, slow speech development. It's not always obvious. Okay. So the way I inherit my chromosomes, the way you inherit your chromosomes, there's different ways, different patterns of inheritance. Dominant, there are some dominant genes. There's recessive genes. There's genes within the chromosomes that cause the inability to metabolize certain foods. And then there's other X-linked, and you don't have to know these, but just to help you understand some of the we call them autosomal recessive inheritance. And what we mean by that is that a mother or a man and a woman who conceive, that man and that woman are carrying certain sets of genes, right? We all carry genes. There's some abnormal genes out there. There's a gene that causes cystic fibrosis. There's a gene that causes sickle cell. There's a gene that causes beta thalassemia, which is an anemia. There's a gene that causes PKU. There's a gene that causes this, a gene that causes that. But this list in particular, cystic fibrosis is kind of common to you, probably. Sickle cell, I know is common. These are recessive genes. In other words, a mother has to carry the gene for sickle cell. The father has to carry the gene for sickle cell. If they both carry it, then there's a 1 in 4 chance that one of their children is going to have sickle cell disease. Okay. So we carry genes. So we can draw blood. So when a mother comes in for her first prenatal visit, and nowadays everybody is blood is drawn and checked for the gene for cystic fibrosis. So it's carrier screening. We check for cystic fibrosis. If there's a family history of sickle cell, then we want to draw sickle cell and screen for that gene. We want to see if mother carries PKU gene or baby carries a PKU gene. Oops. And then there's also another way that we inherit genes, and that's dominantly. In other words, it's a greater risk. So 1 in 5 children are going to have the disease. Half of them, I should say half, 50%. So out of 4 children, 2 of them are going to have that particular disease. So polycystic kidney disease, you might not be familiar with some of these, but neurofibromatosis, von Willebrand is a bleeding disorder. Marfan syndrome is a dominant inheritance, and it causes heart problems and other things. So that's what we mean by carrier screening, okay? So as we think about the history or the physiological and the microbiology and genetic information from parents that influence the development of a baby, there's other things that can influence or cause problems. Mother's exposure to chemicals, hazardous materials, malnutrition. I read an article not long ago that iron deficiency anemia at the time of conception can lead to autism. Okay, so this is something. So nutrition is extremely important. Chronic diseases, drugs, all kinds of drugs, prescribed, non-prescribed, street drugs, infections, exposure to radiation, other chronic diabetes or hyperglycemia. A mother, and we'll talk about it later, but a mother that comes in pregnant and she has a glucose level on a daily basis. In other words, her last A1C might have been 10 points or 10. And that pretty much ensures that her baby's going to be defective. Okay. So we have to assess a really good history on our client about not only her family history or about her history, but her family history. Okay, enough of history. Let's talk about pregnancy. Okay, so conception. When mother is ovulating around between in the menstrual cycle between days 12 and 14, 15, something like, not always, not every woman does it, ovulates at the same time. If sperm is in the area, sperm can survive in the uterus and the fallopian tubes for like 24, 48 hours. So she could ovulate and she could have had sex the day before, and that's when she conceived. Okay. All right. So you don't have to know details about embryonic development. You do need to know the term zygote, right? You need to know that this zygote begins to multiply and divide and grow in the fallopian tube, begins to travel as after it's fertilized, continues to grow. What makes it grow? Progesterone and folic acid in particular. Okay. Folic acid is necessary early in pregnancy because it allows abundant cell growth. Okay. Progesterone feeds the egg and causes preparation, not feeds the egg, it causes preparation of the endometrium. In other words, the inside of the uterus, the lining, the fat lining, the inside, where the egg is going to implant. We need progesterone to keep that nice and vascular for implantation. So implantation takes place between 7 and 12 days. So 7 days after conception, or 7 days, I should say, after fertilization. It's a fine detail. After fertilization, the blastocyst then implants, and it's embedded in that endometrial lining, being fed by the mother's blood. Okay. And then at day 15, it's considered an embryo. So between day 15 and anybody know when the embryonic stage is complete and the baby enters the fetal stage?
8 weeks.
Yeah, 8. At the end of 8 weeks, going into the 9th week, then is considered a fetus. Okay. Okay. So at the end of at 6 weeks, even before during the embryonic period, 5-6 weeks, the baby's heart is beating. We can't see it yet, but it is beating. Actually, I think it begins beating at 3 weeks. Okay. So all structures are in place by the end of 8 weeks, everything. Nothing's mature yet, but the structures are in place and functioning. Okay. So let's talk about, and so we'll talk more about the placenta and the umbilical cord here in a minute. Let's talk about some things, other things you need to know. So Nagel's rule. So you have your mother show up at the clinic, and we're going to talk to her. Okay, let's think about this. When is her baby due? So we've determined she's pregnant. So when is her baby due? We can use what's called Nagel's rule, and you need to know Nagel's rule. So we start with the first day of her last menstrual period. And then we subtract 3 months from that and add 7 days. So if your client tells you that the first day of her last menstrual period was June 10th of 2021, I can change that to 22. Oh, no, I can't. 21. When would her baby be due?
March 17th,
March 17th, what year?
22.
2022.
Okay, so remember, we got to go back 3 months, so that would be March. Add 7 days to the 10th would be the 17th, and then a year would be 22. So she's already had her baby. Okay, so that's how you do that. And then also, we have our client in the office. Now, let's talk about the symptoms and signs of pregnancy. Okay, the group of symptoms or the symptoms, the subjective feelings that mother has are called presumptive. In other words, we're going to presume that she's pregnant because, oh, she's sick to her stomach, she's throwing up. Her breasts are tender. Amenorrhea. What does that mean?
No period.
Yeah, she's missed a period, at least one period. Okay, amenorrhea, no period. Frequent urination. Quickening. What's quickening?
Isn't that when
Anybody
you
know?
feel like the movement in the belly?
Okay, so this is when she feels a baby moving in her belly. Okay, so this is later on. This is usually not until week 16. Okay, those are symptoms because she's feeling them. We can't measure them or we can't see them. So there's symptoms. They're subjective. So we're presuming she's pregnant. Once we talk to her and get her history and do her vital signs, and then the provider, I'm going to examine her. Okay, we're going to do a head to toe assessment. And we're also going to do a belly check. We're going to do an external examination of her vulva. And then we're going to use a speculum. And we're going to visualize her cervix. And if she's pregnant, or if I'm looking at her cervix and it has a bluish tinge to it, a blue tint, a blue, the inside of her vagina might be blue, very light blue, or I should say, it's really darker blue. It's called Chadwick's sign. It's a probable sign of pregnancy. Or if her cervix, when I palpate it, it's soft. It's easy to manipulate. And if the endocervix portion, the Hagar sign, the isthmus, is soft and pliable, causing the uterus to flex forward, it's called Hagar's sign. So these are the probable signs of pregnancies. In other words, I'm doing my examination. She comes in the office, she makes some statements, she describes her symptoms, and we're presuming she's pregnant. And then I'm doing my examination. And I see that her vagina, her cervix have a blue tint to them. So that's Chadwick's sign. And her cervix is soft. That's called a Goodell's sign. She has a positive pregnancy test. That's a probable sign. Does anybody know why it would be probable to have a positive pregnancy test? Why do we call that probable? When we take our little dip of urine and we put it on the little cartridge.
She could be
It can be
taking
like a
HCG
false.
It could,
supplements.
pardon?
She could be taking HCG supplements.
Okay, so it could be a false positive. Other things can cause positive pregnancy tests because it's looking for the HCG. Okay, certain medications like I think epileptic medication can cause a positive result. So that's why we leave it at probable. It's not a positive pregnancy test. Okay. Positive pregnancy is when we see the baby or we hear the baby's heartbeat. So an ultrasound, if we had an ultrasound, yep, she's pregnant. There's the embryo or there's a fetus and I see the heartbeat. Or I use my Doppler on her belly and I hear her fetal heart tones. Or if she's later in pregnancy and didn't get any care and I can put my hands on her belly and I feel baby moving, then I can say she's pregnant. Okay, so those are presumptive because she's talking to us and telling us. Probable because I'm looking at her. And positive because we saw the ultrasound or we hear the heartbeat. Okay, so let's talk about the different structures of pregnancy. Amniotic fluid surrounds the baby. It's an amniotic sac. We call it the membranes. Okay, the membranes. It's a double layer membrane. One side faces mom and the other side faces the baby. Actually faces the placenta, I should say. It covers the placenta on the outside and around the cord. Okay. Amniotic fluid just allows the baby to move around, to float freely. It allows the cord to float freely. Amniotic fluid initially is produced by mother's plasma. And as the baby as the fetus grows, and by week 12, some of the lungs begin to produce amniotic fluid. And then urine from the fetus also produces fluid. So all of that fluid surrounding baby is very beneficial. It keeps the baby warm, keeps it in that ambient temperature. It allows the baby to bounce instead of being jarred. So it's got some shock absorbing features to it. But that's usually all it does. But that's very important. It doesn't serve any other function. Okay, but that's very important. And then we have the placenta. Placenta is a critical part of pregnancy. Okay, we refer to the placenta as the exchange organ. The placenta is considered an organ. However, it's just temporary, right? Just during the pregnancy, but it is an organ. So it's called the exchange organ because that's where all the nutrition and the blood is exchanged. Okay, so the placenta is mature at week 12. Prior to that, the mother's blood and I should say the egg yolk is providing, progesterone is providing what the baby needs. Let me check chat here real quick. Okay. Placenta does a lot other than exchange. It also produces progesterone for the pregnancy. Progesterone is considered the maintenance hormone. I got a fly. Okay. It provides gas exchange. So if you look at a placenta, look at the side view of placenta, the mothers and the fetal vessels actually don't connect, but they're very close together. And what happens, the mother's blood, within the mother's blood, the oxygen is transferred by diffusion into the fetal blood. Okay, and then the carbon dioxide of the fetal blood moves to the mother's blood. So there's an exchange that takes place. Nutrition from mother's blood is actively transported to fetal blood right there at that junction in the placenta. Okay. So gas exchange and nutrition exchange and waste products then return in the same manner from the fetus. So that's your placenta. Placenta is you might say, Grand Central Station of the pregnancy. if the placenta is not healthy, it's not a healthy pregnancy. I got a fly and I'm going to get him. Yeah. And then we have, then in the pregnancy, there's a umbilical cord. Okay. This connects the fetus to the placenta. Okay. The only purpose of the umbilical cord is a channel. Okay. The umbilical cord doesn't do any exchange, has nothing to do with temperature or fluid. These are where all the blood vessels are of the fetus. It's I refer to it as a channel. So, and it's got a substance surrounding it, surrounding the vessels inside the umbilical cord. You can see in the picture there, it's very small, but there are 2 arteries and 1 large vein. And surrounding those vessels is a substance called Wharton's jelly. And it just keeps them moist. It keeps them, again, it keeps them from trauma. It helps. Okay. And that's the only thing it does. It's where the blood flows from the placenta to the fetus. So here's a picture of the different flow of blood, a normal heart or an adult heart, how it flows, and then the fetal blood. The flow of blood through a fetal heart is different than using eyes, yours and mine. Using eyes, your and mine. Okay. There's ducts, there's shunts, you might call them shunts, that prevent blood flow in certain areas and allow them in other areas. So you have ductus venosus. It shunts the blood away, the blood coming through the umbilical cord to the fetus. It shunts that blood, a lot of it, away from the liver. The liver gets some oxygenated blood, but a lot of it is shunted up into the right atria. So the vena cava, inferior and superior and inferior both dump blood into the right atria. Some of that blood goes into the right ventricle. Some of it passes through what's called the foramen ovale, and that's an opening between the atria. And then there's another duct called ductus arteriosus, which shunts blood away from the lungs. Remember, during fetal life, baby doesn't breathe. The lungs are non-functional. All the blood the baby has oxygen in it. We take a deep breath, goes to our lungs, and the oxygen is moved into the blood. And the carbon dioxide is moved from the blood to the lungs, and we breathe it out. Whereas a fetus, that function doesn't occur because the blood coming into the fetus is already oxygenated. Here's a really good video I gave to you. I have this under the announcements, a link to it so that you can watch it. It talks about the blood flow through a fetal heart. Okay, so as we do our mothers, this is kind of out of order, isn't it? Let me move this one up here. Okay. So when we're doing our mother's history, we need to know her GYN history, her OB history. Has she had any pregnancies before? So you need to know the GTPAL categories. This is how we basically categorize her pregnancies. Okay, so gravida means pregnancy. Para means pregnancy beyond 20 weeks. Okay, so we didn't talk about just basic information, but the first trimester is weeks 1 through 13 or 1 through 12. The second trimester is 13 through 26. All right, yeah, 25. Third trimester starts at week 26 and then to the end of the pregnancy. So a pregnancy that reaches 20 weeks and is delivered at 20 weeks or after is called a para. A pregnancy that is delivered prior to 20 weeks is called an abortion. Okay, that's the medical term, abortion. In the past, we referred to it as a miscarriage if it's spontaneous. But now medically, they're all called abortions. Okay, so any pregnancy or any conception prior to 20 weeks that was lost is called an abortion. Okay. So a full-term pregnancy begins at 37 weeks. 37 to 42. Anything after 42 is considered post-term. A preterm pregnancy is a baby that's delivered less than 37 weeks, but after 20 weeks. So between 20 weeks and 37 weeks, or 36 weeks and 6 days, it's called preterm. Okay. And then we talked about, and then the last column, the L in GTPAL, is how many babies were delivered alive, or how many living children. Okay. So let's practice. Okay. So you need to know how to do this. I know this is on your quiz. Okay. So if a pregnant woman comes to the office and she says, I've delivered 2 full-term babies. I had 1 preterm delivery, 2 spontaneous abortions, and I had a stillborn, which means the baby was delivered dead. Okay, so that's stillborn. She had a stillborn at 28 weeks. So what's her GTPAL? So you have this information. The first thing you want to do is ask yourself the G question. How many times has she conceived?
That'd be 6.
So 6 times. Okay, so she's had 2 full term, 1 preterm, 2, so that's 5. She had 1 stillborn, that's 6. She's pregnant now.
So 7.
7, right? 4, 5. Yep, 7. Because she's pregnant currently, remember?
Right, so that's 7.
So her G is 7. Okay. She delivered 2, 1, 2, 1. Plus she's pregnant now, currently, when she comes in. So her G is 7. Okay. How many times has she conceived? And then from those conceptions, the T, how many of those conceptions were delivered alive after, well, I shouldn't say that. How many of those conceptions were delivered from 37 weeks on?
2. 3.
37 weeks would be full term. So how many full term deliveries does she have?
2.
2. Okay, she's delivered 2 full term babies. And then the next column, the P, how many babies were delivered between 20 weeks and 36 weeks and 6 days?
2.
2.
2.
Okay, somebody tell me why it's 2.
One
Because she had
stillborn and 1
the
preterm.
preterm and stillborn.
The preterm and the stillborn. Yeah, she delivered it, even though the baby wasn't alive. She did deliver the baby. Okay. And it was between 20 and it was after 20 weeks or after 37 weeks. What am I saying? Stillborn between 20 and 36 was the preterm. Okay. And then how many abortions has she had?
2.
2. It tells you there. So how many living children does she have?
3.
2.
3.
Okay. we assume that the 2 full term and the 1 preterm are alive. Okay. Yeah, we make that presumption. Okay. So that's how we do that. It takes some practice. I don't think I can change that because I did it differently. Okay, good. So we talk about physiological changes in pregnancy, and this is a great picture because it goes through the systems. So when a woman conceives, all of a sudden, all these changes begin to develop. So we're talking about respiratory system, cardiovascular system, the GI system, hormones, integumentary, the renal system, the musculoskeletal, what else? And weight and all that. So what we're going to do, we're going to break out into groups now. And I'm going to assign you all to different groups. And let me check my chat again. Okay. If you leave to go to the bathroom, as long as you come back, you don't have to tell me. I don't need to know your bathroom habits, but thank you very much. Okay, so let me share the questions I'm going to have you answer. So I'm going to divide you up into 6 different rooms. Okay, the first group is going to explain to the rest of us the blood flow through an adult heart. Where does it come into the heart? Where does it leave? How does it flow through the heart? The second group is going to describe the blood flow through the fetal heart. Now, I would suggest you go to the text for that information, but the adult heart might be in your text. I don't even know. Okay. So however you can get that information. Okay. If you don't know it. And then the third group is going to tell us the physiological changes in the respiratory system during pregnancy. The next group, the gastrointestinal changes. And then the next group, the changes in the kidneys or the renal system. And then the last group is going to be the integumentary system. And then I'll mention some other things. Okay. So I'm going to divide you up. It's 4:03 right now. So I'm going to add in a break time. All right. So I want you to be back here ready to go at it's 3 after. Let's be back ready to go about can you take a break and get your stuff ready by 20 after? You think? Is that enough time? If you can't get it all done, that's okay. I'll fill in. Okay. So I'm going to break you up into rooms and then I'm going to come into each room and tell you what your assignment is. Okay. Okay. Because you don't know what group you're going to be in. Okay. Let me see here. Let's see. Let me do something. Okay, when you get your invitation, click on the invitation and you'll go to your room.
I don't see it. I don't see it.
Okay. I'm gonna wait a few seconds here.
Did you send me one?
I guess nobody got one yet.
No, not yet. Still waiting.
All right, let me fix this. Okay, now you should be getting your invitations.
Hey, I'm sorry. I'm the one that has the.
Lori, let's see. Hang on just a minute.
Hey, I'm the sorry, I'm the student that has the dialed in on 2 different devices.
Oh, okay,
So they can
okay.
hear me on the. I'm just gonna hang
Okay. Can you see the breakout rooms? You might not be able to.
Yes, I'm in
Okay,
there, but
join,
they
just,
can't.
okay.
But they can hear
Oh.
me, so I mean,
Oh,
sorry.
Okay. Everybody should be back by now. All right, group 1. Describe the blood flow through the adult heart, group 1. Who's speaking?
Janaya.
Janaya, go ahead, Janaya.
Okay, so what we came up with is that deoxygenated blood leaves the body tissues and goes through the superior and inferior vena cava and goes to the right atrium through the tricuspid valve to the right ventricle and then on to the pulmonary valve and to the pulmonary artery and into the lungs, where then oxygenated blood leaves the lungs through the pulmonary veins into the left atrium from the bicuspid valve to the left ventricle and to the aorta.
And out the body. Good.
Yes.
All right, great. Room 2. Fetal heart blood flow. Who's the spokesperson for group 2?
We never really decided, but I guess we had 13 seconds left, and I think we were gonna say, and then we didn't have time.
Okay.
We found that it says a small amount of highly oxygenated blood from the inferior vena cava remains in the right atrium and mixes with poorly oxygenated blood from the superior vena cava. This medium oxygenated blood then passes into the right ventricle. The poorly oxygenated blood returns to the placenta for oxygen and nutrients through the umbilical arteries.
Okay. So we have blood coming through both inferior and superior vena cavas into the right atrium. Some of it goes through the foraminal valley into the left atrium. Some of it goes to the right ventricle. Okay. The blood that is in the left atrium then will go to the where does it go after that? It goes to the pulmonary artery. No, where does it go after that?
Superior vena cava then passes into the right ventricle.
Uh-huh. The other one goes through the right ventricle up the pulmonary artery, right?
Mhm.
It bypasses the lungs, right? So that's your ductus arteriosus. It bypasses the lungs and goes into the aorta. Okay. On the other end, it goes from the right atria through the left atria into the aorta and out. Okay, good job. I know it's difficult. I think when you watch the video, it's hard to say. Okay, good. How about room 3, physiological change in respiratory system? What's going on?
I guess we didn't really choose either, but I don't mind if you can hear me over the music. Sorry. So O2 consumption is about 40% above normal levels, and that's to support the fetal growth and the placenta. Also, because of the upward pressure from the growth of the uterus, it pushes up on that diaphragm up to I think 4 centimeters.
Okay. Towards
and
the
then-
end of pregnancy, yeah.
Yes, ma'am. And then the rib cage ligaments relax due to the progesterone, which allows for more chest expansion.
Good.
And then dyspnea occurs commonly, and you're pretty much in a chronic state of hyperventilation.
Yes. So mild hyperventilation. So she's breathing in more oxygen or more air. Good. Good. All right. GI system. Who's next?
So pretty much we just gathered the stuff from the PowerPoint and then a little bit extra and then some interventions. So just pregnancy gingivitis, increased saliva, decrease in gastric acidity, hemorrhoids, constipation. It's harder to empty the gallbladder. The tone of the smooth muscles decreases. So I guess that kind of goes hand in hand with the constipation. And then also just, we were talking about how with pregnancy, things become a lot more like vascular. So increase in blood flow in that area because it's kind of all going to the fetus. So also there's vomiting, heartburn, decrease or increase in appetite, kind of depending on what stage she is at. Indigestion, and we said just for interventions, an increase in fiber to help with constipation. The question we had was like, obviously, because there's going to be a lot more heartburn and indigestion, would antacids, like, is there any healthy ones that like are allowed to be taken or not? Because we looked it up, but we didn't really get like an exact answer.
Okay. An occasional antacid like Tums is okay. But remember, those kinds of antacids are going to constipate even more.
Yeah, okay. But
Good.
then we also said like soft toothbrushes for the gingivitis, because like her gums are going to be bleeding a lot, and then an increase in fluid intake because she's going to be more likely to become dehydrated with everything she's got going on. So
Excellent. So GI motility slows, peristalsis slows, and that's the reason for heartburn and constipation also. Good job. Okay, what about kidneys, renal system? Not a whole lot, but some.
We all kind of had like our own topics to discuss in the renal system. But
Pardon?
so, like we all broke down what we were going to talk about each.
Okay, great. Go ahead.
So I had function. The renal plasma flow rises significantly early in the pregnancy. It peaks at 60 to 80% in the second trimester and decreases after 34 weeks of gestation. The glomerular filtration rate increases by 50% during the first trimester and remains elevated. And because of this increased GFR, it results in increased creatinine clearance and a reduction in serum creatinine, your BUN, and your uric acid levels.
Okay. All right. Anything else? Who else?
I did anatomic changes. So it says as early as the 10th week of pregnancy, the renal, pelvis, and ureters dilate.
Okay.
They dilate closer, more to the right because the uterus is heavy, and it is placed to the right by the sigmoid colon.
Okay.
And I was going to say about the fluid and electrolyte balance.
Okay, good.
So because of increase in total body water in pregnant women, to prevent excessive sodium depletion, the kidneys undergo significant adaptation by increasing tubular reabsorption. However, in pregnant women, tubular reabsorption of glucose is impaired, so possibility of gestational diabetes is very likely.
Okay, excellent, excellent, excellent. Anything else in that group? She's more susceptible to urinary tract infections because of the stasis, the dilation of the ureters. So she's more prone to urinary tract infections. Good. And then lastly, and then of course we left off one group, but integumentary, there's some changes in the integumentary system. So the skin. Go ahead.
So we have the hyperpigmentation, and that was due to the increased melanotropic from the anterior pituitary hormone, and the darker nipples, the areola also darkens. The underarms or the axilla, the vulva, because of the blood flow. And in darker complexions, they have what's called melasma, which is usually in around the cheeks, the nose, and the forehead. Most women, but not all women, will get the linea negra, which is a darker line that goes from the symphysis pubis down to the fundus midline. And some women, not all women, also get the stretch marks, which is called striae gravidarum.
Okay.
Also some angiomatas, which is vascular spider due to the increased blood flow, and the increased estrogen, as well as some of the other hormones would give, like the palmar erythema, which is like the red
Okay. Yeah.
of the
The
palms
hands.
or the hands, yes. And then the increased hair and nail growth. Sometimes it makes hair that was more brittle, it might make it more softer or thicker. Some women actually have thinning of their hair, and then some women also develop acne while they're pregnant because of the hormones. And then we talked about the glowing of the skin that a lot of people experience or even get brought to their attention, but that's due to the increased hormone levels also.
Yeah. Yeah. Wow, that's great. All right. And then the last system I'll do is the musculoskeletal system. And in the musculoskeletal system, because of progesterone and the hormone relaxin, a lot of the ligaments are relaxed during pregnancy. And specifically the ones around the uterus. The uterus has 3 sets of ligaments that's suspended. And as the uterus grows, a woman might experience some sharp abdominal pain. And then her lower back becomes a more swayed appearance. So she could have back pain early in pregnancy and progresses throughout pregnancy. So thus the musculoskeletal system, the changes. And the uterus is a smooth muscle. And so it is going to be much more relaxed during pregnancy as well because of progesterone. Good job. Thank you, everybody. So we've got some more stuff to go over here. So cardiovascular system, we talked about, the nasal congestion because of estrogen. Estrogen is what helps grow the breast and the uterus itself. So the uterus expands exponentially. It's got a lot more blood flow. It can contain up to 5 liters of blood itself by the end of pregnancy. And the reason we want more blood flow through the uterus is we want a strong muscle for labor, and we need a lot of blood flow for the placenta and the fetus. Okay, the fetus is able to carry more oxygen in its blood than we can. There's more hemoglobin available on their red blood cells, so they're able. So if you see in the diagram for fetal heart blood flow in a house, some of the blood looks like it's not oxygenated well. It actually is because of the capability of the fetal red blood cells. So during pregnancy, the volume of red blood cells nearly doubles. The plasma increases even more. Okay, so cardiac output is increased during pregnancy. So you have a greater stroke volume and usually a faster heart rate. So the cardiac output is greater. So the heart is working really hard during pregnancy because of all the extra volume. And that's why you see the extra renal, the glomerular filtration is because there's so much more blood. Okay. So because of the increase in plasma, more than the red blood cells, there's almost like a dilution. Even though she has more red blood cells, it looks diluted. And there's a false anemia at times during pregnancy. Now, there's also anemia of pregnancy, but sometimes there's only a delusional or a physiologic anemia of pregnancy because of all the extra plasma that is developed for pregnancy. And then also the hemostasis system. During pregnancy, fibrinogen, it is a clotting factor. There's higher levels of fibrinogen during pregnancy. So she's going to clot more easily. So we have to do teaching about preventing a deep vein thrombosis. Okay. The blood vessels in the periphery are more dilated. So there's a lot more peripheral blood flow. So another reason for blood clots. So we want mother not to be, as she progresses in her pregnancy, we want her to remain active and not sit still for long periods. We don't want her riding in the car for more than 2 hours without moving, without getting up. The same thing with any travel, airplane, any kind of travel. Another concept about blood flow during pregnancy is as that fetus grows and mother becomes even more gravid, if she lies on her back, that fetus can actually compress the vena cava and the aorta. And that reduces blood flow to the fetus. It reduces mother's blood flow to her brain. So she might feel a little lightheaded when she lies flat. And this information is going to be more significant when we get to next week, when we go into labor and delivery and monitoring the baby. So quickening, remember that term, we already talked about it, but it's what mother feels. It's a perception of fetal movement. And I think your text says week 18 to 20, 16 to 18, I don't remember, it's changed. But usually women don't feel this super early. Now, if they've had 4 children, they might recognize it sooner. So we went over the changes in pregnancy. So let's see if we can match some things here, okay? So respiratory system. So there's a column on the right. Which one of those pertain to the respiratory system? Anything?
Nasal congestion.
Yeah, maybe some nasal
congestion.
congestion. Yeah. But that's really more hormonal. I don't think I put it. Increased tidal volume. In other words, the amount of air she inhales and then exhales. So tidal means the amount of air inhaled. And then that same tidal is exhaled. So increased tidal volume. Remember, we talked about mild hyperventilation. So she's consuming, she needs more oxygen. Okay. What else? Can you match up? Can you match up any integumentary changes here?
Melasma or colasma.
So the facial changes, the darkening of the face. Yeah. Anything else? What about GI system?
Constipation.
Constipation, definitely. That's what pyrosis is.
It's a heartburn.
Heartburn, yeah. So heartburn is common. It's common during pregnancy. We teach a bland diet if she's having a lot of trouble, and to eat smaller meals throughout the day. Okay. Avoiding spicy type foods, but the volume of food she eats, it needs to be reduced because the stomach is not digesting as quickly. Okay. Musculoskeletal system.
Ligament pain.
Ligament pain and even constipation, the slowing of the peristalsis. Okay. What about renal system?
UTI.
Yes. And so hormonal change, immune system would be what?
Tdap.
Tdap, yeah. The Tdap. So during pregnancy, the immune system is quiet. In other words, it's not as responsive normally. So it's easier for a woman who's pregnant to get an infection. So we do want to boost her with a Tdap, and we usually don't recommend that until the second trimester. Can we give rubella during pregnancy?
No.
No. Any live virus we cannot give during pregnancy. So no rubella, no Gardasil, no varicella. Okay, we don't give those during pregnancy. And then hormonal, sore breast. Yeah, sore breast or hormonal, so progesterone. Hormonal pregnancy maintenance. So progesterone again, nasal congestion, estrogen. Okay. All right, so some other things that we do during that first visit. When we do, remember we do carrier screening. Do I have this in here? I don't think I do. This is not carrier screening. This is called maternal serum marker screening. In other words, we're looking for markers in the blood that indicate information from the fetus. So we're going to draw mother's blood to see if we can get some information about the fetus. Okay. So some of those markers are called MS-AFP or AFP. This is estrogen and this is HCG. You don't have to memorize this. Okay. What you do need to know that elevated AFP levels, maternal serum AFP, in other words, because it's coming from mother's blood, the AFP levels, if they're low in mother's blood, there's an increased risk for baby having Down syndrome. If the AFP level is high in mother's blood, there's an increased risk for neural tube defects, such as spina bifida. Those are the only two that you need to know, the AFP. Okay. So we do this usually after week 11. Okay, so it depends when she comes in for her prenatal. And then remember we talked about chromosomes. We do carrier screening. So we're checking for abnormal genes, cystic fibrosis, sickle cell disease. So that's carrier screening, 2 different blood tests. Okay. Let's see. Ultrasounds during pregnancy. We don't always do an ultrasound in that first trimester because we don't really see a whole lot. But there are some reasons we need to do an ultrasound. And one is to just find out how far along she is. We might, yes, Janaya.
Do you mind repeating what NTD stood for again?
Neural tube defects. And that's usually something like spina bifida, which is an opening of the neural tube. It wasn't closed completely. So we promote folic acid to prevent that from happening. Sometimes we can sometimes attribute the development of NTD because she did not get enough folic acid. So incomplete development of the spinal column, the closure, NTD. So you're going to see an elevated AFP.
Thank you.
Sure. So the first trimester, we can do an ultrasound to see how far along she is. If she doesn't remember when her last menstrual period was, or if her periods are irregular, we need to do an early ultrasound before that 13th week. And then we can measure the size of the fetus and it correlates with the age of the baby. We can also verify if there's a twin pregnancy. Sometimes we need to do an ultrasound to look for any abnormal uterine anatomy. Or maybe she's having an ectopic pregnancy. She comes into the office, she's having pain. And we're going to do, and she's not bleeding. So we're going to do an ultrasound to see, make sure that baby or that pregnancy is in the uterus and not the fallopian tube. Okay, so the ectopic pregnancy, you're doing a case study on ectopic pregnancy. Okay. Did I give you all the ectopic pregnancy information in a document? Did I give you a document that I wrote up about ectopic pregnancy? Do you remember?
I don't think so.
Okay.
It wasn't in document form. It was in the form of an email. So it wasn't
okay.
Downloaded. It was something that was like information that you could.
Okay, good. I sent that by email. Okay, good.
Yes.
So everybody look for that. And that'll help you too about ectopic pregnancies. Okay. If a woman is very heavy and she comes in, let's say at 14 weeks, and I've got my Doppler and I'm hunting for fetal heart tones, I can hear that baby's heartbeat with a Doppler on her belly at 9 weeks. If I can't hear it, I'll have her come back in another week and I'll try again. So if I can't hear it because she's got a lot of adipose tissue, or maybe the placenta is in the back, or the baby's farther in the back of the uterus and still very tiny, we'll get an ultrasound for that. Okay, so there are reasons to do it early. Very commonly, we do it more often in the 3rd trimester. We do every woman anatomy ultrasound at 20 weeks. And if she's high risk, we're going to do more ultrasounds to watch the baby grow and such as that. Look at amniotic fluid levels. How much fluid does she have? We can do a BPP, and that would be in the 3rd trimester. And we're going to talk about some of these things later. Non-stress tests. This is a non-stress test is just hooking mom up to a monitor to watch the baby move or watch the baby's heart rate. There's some great pictures in your book. Okay, so you can look at the non-stress test. So what we do is we hook her up to a monitor. We're watching the baby's heart rate only. And she's going to push a button when she feels the baby move. And at that point, we want to see the heart rate of the baby go up. And that's a positive response. It lets us know that baby is well oxygenated. Okay, so that's the non-stress test. So positive or reactive, the baby reacts, the heart rate goes up. We can also do amniocentesis for 2 separate reasons. We can do it early in pregnancy to do some blood work. Let's say we did her alpha fetal protein, the maternal marker screening for abnormalities. And let's say it was abnormal. Her AFP was too high. If we draw amniotic fluid from around the baby, we use an ultrasound as we do this. With a needle, we're going to draw some fluid and find out what the AFP levels are in the fluid. And that's a more specific and sensitive test. And if the AFP is elevated from the fluid, then we know it's a greater risk and we can diagnose spina bifida, or at least have a pretty good idea the baby has spina bifida or some kind of neurotube defect. So we usually do the blood first, an ultrasound, and then amniocentesis, although they're not doing them as often nowadays because we can see a lot on an ultrasound. Another reason to do an amniocentesis is later in pregnancy to determine if the lungs are mature. Okay, so we can look for a certain substance in the amniotic fluid that lets us know the lungs are mature, and that's called the LS ratio. And it should be 2 to 1. So everybody, you need to know this part. You need to know that the fetal lungs usually are mature at 35 weeks of pregnancy. And that's when the LS ratio is 2:1. Okay. In other words, there's enough of that surfactant inside that alveolus in all of the alveoli to allow them to expand for gas exchange after delivery. Okay. So lung maturity, 35 weeks, LS ratio of 2:1. And we know that the baby's lungs have enough surfactant for respiratory exchange. Nutrition. Some important things about nutrition. PICA, P-I-C-A, indicates iron deficiency anemia during pregnancy. So what is PICA?
Pica's like when you eat things that aren't edible.
Right, eating something you're usually not supposed to eat, like
Or
what?
no nutrition.
You said like what?
Yeah, for example.
When pregnant women get those cravings and they eat dirt, or they get those cravings for dirt.
Yeah, my dog had
Yeah.
pica and ate drywall.
Yeah,
Yeah.
yeah, chalk, dirt, that's pica. There's some kind of deficiency. And in pregnancy, if that occurs, it's usually an iron deficiency. Okay, so I put this in here, made this chart for you because you need to know what foods you'll find vitamin B12. There is a difference between iron deficiency anemia and vitamin B12 deficiency anemia. So you need to know the foods that those substances are found in. And during high risk, we'll talk about PKU. Vitamin K, normally produced by our gut. If someone eats a lot of greens, they have ample vitamin K. But if you're taking warfarin because you have a bleeding blood clot, or you have a tendency to clot, you're going to avoid vitamin K foods. Okay. Folic acid, important, 400 micrograms a day. And usually prenatal vitamins have it. So those are the foods: citrus, legumes, beans, other fruits and vegetables. So you can study that, so you know. Okay, so the umbilical cord. Let's answer this question. I'm rushing through this, but we'll get through it. So after delivery of a newborn, we put baby on mother's chest for skin to skin. We've clamped the cord, and then we're going to let dad cut the cord. So the nurse for labor and delivery, the newborn, they're going to look at the cord, and they're going to look to see how many vessels are in the cord. We can see that with an ultrasound, but what's supposed to be in the cord?
3 vessels. That should be 2 arteries and 1 vein.
Arteries, 1 vein.
2 arteries and 1 vein. Which one carries the oxygenated blood?
The vein.
The vein, the big vein. It carries oxygenated blood to the fetus. Yes, the big vein. Good.
May I ask a question about that really quick?
Yes.
So the 3 vessels is considered the mom, the baby, and the placenta, correct?
The 3 vessels are inside the umbilical cord. Remember, we have the placenta and the umbilical cord, and then the fetus. In that umbilical cord is the blood flow to and from the fetus. And so inside it, you need 1 vein. 1 vein pulls the oxygenated blood to the baby, and the arteries, fetal arteries, bring that blood back to mother with deoxygenated blood. It's the opposite. Okay.
Okay. Yes, ma'am. Thank you.
Yeah, I think there's a picture way up here that you can look at again, right here. This one right here. See, there's 1 vein and 2 little arteries in that umbilical cord. Okay.
Thank you.
So good job. Okay. Prenatal visits, we kind of talked about it, and next week we'll be going over our case study. And so you'll get a better idea of the flow of prenatal care, antepartum care. So we do screening, intimate partner violence screening, alcohol, drug screening. We do a history. We draw a bunch of labs. We weigh, we do vital signs. Okay. We check urine every time she comes in, weigh her every time she comes in. Okay. We do fundal measurements, measuring the fundal height, it's called. So we're measuring from the bone, the pubic bone, all the way up over the belly to the fundus, which is the top part of the uterus. We can kind of correlate that with her gestational age. We teach. We want to encourage prenatal classes, Kegel exercises, oral hygiene, all those things. Teach, teach, teach. Okay. What about this question? She's 32 weeks. She's dizzy. We're measuring her fundal height. She's laying on the table. Why is she dizzy?
Would it be to turn her on her left side because she could have pressure on her?
What's going on?
Just lying on her back, supine position, and it's kind of like
Maybe putting pressure on that vein.
Yeah, it's compressing the umbilical or the inferior vena cava and the aorta. So she gets lightheaded. So we got to get her off of her back on her left side. And you'll really appreciate the significance of that next week when we talk about monitoring.
I have a question. Is it like a difference from a pregnant woman laying on her left side or right side, or it doesn't matter long as she's not on like
It's better to do one or the other, but it's best on the left side because of the kidneys. Okay, but if you can't do the left side, at least do the right side. Okay. So you have a 34 weeks. So she's in her third trimester. She comes into the office. What are you concerned about?
The fundal height of 30 centimeters.
Yeah. So it should be, if she's 34 weeks, the fundal height should be what?
Either 32 or 36.
34. It should be 34. Yeah.
Or is it
Once you get above the belly button, then we start correlating the fundal height with the gestational week. So at 20 weeks gestation, the fundus should be right at that umbilicus.
But I thought there is like plus minus 2 centimeters that you have that is still okay range now, wasn't it?
Well, yeah, but we I guess average, but we usually see now if someone has, if it's an adolescent, it might be lower. If you have a lot of amniotic, extra amniotic fluid, it might be higher. If you have a larger baby, it's going to be higher. Okay. But it's a gauge that we go by. If somebody smokes nicotine or uses nicotine, it's going to be lower. Okay. Does that answer your question? Okay.
Yes.
So fundal height of 30, we're more concerned with. A fetal heart rate of 110 is a little low, but it would be something to monitor if she's feeling baby move well. We could do a non-stress test. Edema in the lower extremities is not that uncommon because of the pelvic congestion of blood. ABO and ABO compatibility, I sent you a form on that. So the most important thing to know about this, and it's very difficult, is if mom is Rh negative, that's when we intervene. That's when we have to treat her. If she is negative. Group beta strep. Oh my gosh, I'm sorry I'm going over. If you have to go ahead and sign off. This is being recorded and you can watch it again. Okay. Group beta strep is a bacteria,
I'm sorry.
right?
Sorry to disturb you, but I have an emergency. But how can I get the recording? Because I've been trying.
I will post it in the announcement under week 2.
Okay.
Okay.
Did you post week 1?
Yes, I did.
Okay. Thank you.
You're welcome. Okay, so group B is a bacteria. It's not the one that causes sore throat. That's group A. This is group B, a different one. And if you remember microbiology, sometimes we colonize bacteria. In other words, it's just there. It doesn't mean we have an infection, it's just there. But if a woman has group B in her vagina, in her urine, or her rectum, it can be transferred to the fetus during delivery and cause meningitis, pneumonia, all kinds of bad things. So we screen everybody for group B, every pregnant woman for group B, usually at 36 weeks. We do cultures and then we treat accordingly. So she'll get medication, penicillin or clindamycin or cephalosporin during labor if she's positive for group beta strep. Leopold maneuvers, basically finding out the position of the baby. High risk, we'll get into that. A social reason that she could be high risk, physical reason that she's high risk. So all the, psychosocial and such reasons why a woman would be considered high risk. And then next week, we'll be talking about labor and delivery. We're week 3 already. So read chapters 13 through 16. Do not work on NCLEX until next week. And so watch a video that I'm going to be posting about how to do NCLEX. I am sorry I went over. I don't like to do that, but there is a lot of stuff to go over this week. Any questions about anything before you sign off? Don't forget your attestation.
Are we gonna for McBride's class? Are we gonna get the same recording?
I will share it with her. Yes, she will ask for it anyway. Yes.
Making sure. Okay, thank you.
You're welcome. You're welcome.
And
Thank you for coming. I hope you enjoyed yourself. I know it was
So
a
we're gonna
lot.
have Dr. Seller, are we gonna have an exam next week?
No, week 4.
Week 4, okay.
Week 4. So next week we do reviews. So I will be sending out the schedule when the instructors are reviewing, and I'll send you a study guide and I'll send you a PowerPoint to prepare.
All right.
Okay.
Yes, ma'am. Thank you.
You're welcome.
Have a good day. Bye.
You too.
I wanted to ask about if you could go over 12B, because I thought that even though me and you discussed it, that they're still going by the hour. So we can only set it by the hour for the IV. So increasing it, she would get more within that 40-minute span.
It's a 30-minute. So if you come, yeah. So yeah, it says 30 minutes. They want 150 mLs in 30 minutes. So you need to get it in, all of it in at 30 minutes. So how are you going to set your pump up?
So it has 40 minutes for number 12 for 12B.
No. It says a magnesium sulfate bolus of 6 grams to be infused over 30 minutes.
I'm sorry. Okay.
Yeah. Yeah. So if you need to get that amount in 30 minutes, remember we talked about setting up that proportion,
Yeah.
150 ml, 30 minutes, X ml, 60 minutes. So we determined that X was 300. So you're doubling the rate. If you set your pump for 300 mLs an hour, that 150 ml solution will be finished in 30 minutes.
Okay. So we just.
Yeah, a lot of students miss that one because they missed the 30 minute.
Okay.
Okay.
All right. Thank you so much
So
for your.
you are welcome. You are welcome. Any other questions?
I had a question about quiz. I don't know if you touched that because I jumped later on the Zoom. Is anything particular will be on the quiz that we need to look for, or everything that we covered that up until now?
Yeah, you need, I do know, you need to know your GTPAL. You need to know about AFP. So those are the major things. I don't know if there's Nagel's rule on there or not. Yeah, they're just the major things we talked about today.
Okay, thank you.
You're welcome. And just study the slides. You'll be able to answer the questions if you just study the slides.
Or I had a question about number 4 on the math, because I think that was the only one that I needed, that I didn't understand, that I needed to correct.
Okay.
I looked up, like I saw like an example